Good afternoon. I'd like to wish everyone a happy International Infection Prevention Week. On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Infection Prevention and Volunteers, Contract Personnel, and Other Non-Employees. Before I introduce our speaker, I'd like to ask Joanne Atkins, she's a Senior Infection Prevention Analyst here at the Authority, to share a story with you of why we felt this was an important topic on which to provide education. Joanne?
Thank you, Terry. I worked with a long-term care facility who was experiencing a cluster of infections from the same organism. 2 of these infections were skin and soft tissue infections, but the majority were bloodstream infections. I worked with the facility, and we sat down with our infection prevention team and put on our CSI caps to drill down the infections. We could not easily identify the red flag that connected the infections, so we drilled deeper. We reviewed room placement. We reviewed staffing to look for shared staff that may have cared for these patients, transfers within the facility or to or from the same facility. We then looked at shared therapies and equipment. Nothing came to light as a possible source of transmission of this organism. We then turned our focus on the primary bloodstream infections, looking for similarities. None of the residents with primary bloodstream infections had symptoms indicative of another source of infection. There were no sore throats, urinary symptoms, respiratory symptoms, etc. As the organism most likely had to be introduced systemically, we then looked at treatments. Did these residents receive any type of injection prior to the infection? We ruled that out, and then started looking at lab work. Did any of the residents have lab draws? Record review revealed all of the residents with the infection had lab work drawn 1 to 3 days prior to exhibiting the symptoms of fever, malaise, hypotension, and all had positive blood cultures of the same organism. I then met with staff and walked them through describing how lab personnel performed the blood draws, as the tech was not on site. One of the CNAs related the tech would don gloves, set his basket of equipment on the resident's bed, and proceed to draw blood. Gloves would be removed, but no one could recall hand hygiene being done. The tech would then proceed to the next resident to draw blood. Again, the basket was set on the bed with no barrier between it, and no hand hygiene was observed. This then led to a discussion with their infection prevention team on proper infection prevention, the facility's policies on shared equipment and cleaning and lab draws, and then further discussion on how contracted lab personnel were educated in infection prevention. Did the personnel know and follow facility policies and procedures? The facility was not aware of the training the tech received, which then led to this webinar.
Thank you, Joanne. Now I'd like to introduce our speaker for the webinar. Nancy Pritchard is the Senior Manager of Employee Health Services for the University of Pittsburgh Medical Center. She has oversight of 8 employee health centers and assists with opening new facilities for the UPMC enterprise. She has 20 years of experience in employee health and workers' compensation. Nancy is very active as a board member for Pennsylvania Association of Occupational Health Nurses. Ms. Pritchard received her Bachelor's of Nursing degree at Duquesne University in Pittsburgh, Pennsylvania. Nancy, I'll now turn the program over to you.
Thank you, Terry Lee. Today we're going to talk about infection prevention and volunteers and contract employees, all those non-employees that we quite often get involved with. Our objectives today are to list several types of healthcare professionals according to the Advisory Committee on the Immunization Practices and Definition, articulate when vaccination and immunity status should be reviewed, and list 4 policies that should include all healthcare professionals. Our volunteers are described as volunteers using the healthcare facilities is an age-old practice. The volunteers play a vital role in the variety of support services that contribute to the added comfort and happiness of our patients, our families, and our visitors. And as we know, they're huge in a lot of the facilities I'm in. Our contracted personnel, these are people that are performing defined jobs at a given rate. Their scopes usually encompasses a particular task or project. Other non-employees, these are like your medical sales representatives, or they're called MSRs. They're responsible for selling medical products and services to the healthcare facilities and healthcare professionals. Our HIRs, our healthcare industry representatives, are individuals who sell, promote, and give training and advice concerning medical devices, systems, and procedures. The Advisory Committee on Immunization Practices defines healthcare professionals as all paid and unpaid persons working in the healthcare setting who have the potential for exposure to patients and or to infectious materials. This includes body substances, contaminated medical supplies and equipment, contaminated environmental surfaces, and contaminated air. So that means our examples of our healthcare professionals, these are nurses, sitters, phlebotomists, OT/PT, pet therapists, clergy, teachers, hairdressers, manicurists, construction workers, security. A lot of these can be either contracted or some of our outside facilities that come in. Our healthcare facilities have the responsibility to establish safe practice policies and procedures for all of the healthcare professionals. The healthcare professionals in your facility who have contact with patients or residents must understand the transmission and prevention of disease within the framework of their duties to reduce the risk of occupational exposure to potential pathogens. And my rule of thumb is document, document, document. All of your education, anything that you've instructed them to do, you really need to make sure that's documented. Our plan of protection is to establish plans for protecting the healthcare provider. These may include lists of allowed and prohibited duties. Educate your healthcare providers to understand the chain of transmission of infectious diseases to reduce the risk for exposure to potential pathogens while performing their assigned duties. Evidence of baseline tuberculosis screening before assignment and further testing as guided by the facility's annual tuberculosis risk assessment in Pennsylvania law. Health history that includes immunization status, education about standard precautions, infection prevention practices in specific areas such as the operating room, tuberculosis, bloodborne pathogens, and the risk of exposure to communicable diseases and prevention. Prior to their assignment, consideration should be given to requiring all healthcare professionals to provide documentation of a pre-placement assessment containing the health history, immunizations, and prior exposure to communicable diseases. Review of the healthcare professional vaccination record, immunity status at the time of hire, and on a regular basis, for example, at least annually on some vaccinations, with the consideration of offering needed vaccines if necessary in conjunction with the routine annual disease prevention measures, for example, influenza vaccine and tuberculosis testing. Vaccine requirements. Every healthcare professional should have a two-step tuberculosis test, either an IGRA test on hire. If it's positive, you need to have a procedure on what you're going to do, a surveillance, a chest x-ray. Those would be required in a lot of the healthcare facilities. Measles, mumps, rubella, varicella titers, hepatitis B titer or statement, a Tdap, influenza, pneumococcal if over 65. So we're going to get into the tuberculosis testing. Included in all your healthcare professional should be your exposure control plan. What would you do if there is an exposure? How would a volunteer, a contract personnel, or a non-employee be notified? Where would they go for testing? If they've had a past positive test, did you document if they were symptom-free upon hire prior to the exposure? And what is going on now? Measles, mumps, rubella, these have different requirements. Persons born before 1957 in routine or outbreak context. So being eligible prior to 57, they have immunity, specifically guidance in providing 2 doses of MMR for measles, mumps protection, 1 dose for the rubella protection. History of disease is no longer considered adequate presumptive evidence of measles or mumps immunity for the healthcare professional. Laboratory confirmation of disease was added as acceptable presumptive evidence of immunity. History of the disease has never been considered adequate evidence of immunity for rubella. So it's real important to know what disease you're working with. For varicella, criteria for evidence of immunity for varicella was established. You have to have documented of 2 doses of vaccine or laboratory evidence of immunity or laboratory confirmation of the disease, or you can have documented history of varicella disease by a healthcare provider or documentation of history of herpes zoster by a healthcare provider. But again, a lot of folks that I see come in do not have the healthcare provider documentation, so that's where we end up getting the titers. Hepatitis B, the healthcare professional and trainees in certain populations are at high risk for chronic hepatitis B infection. Do you have a hepatitis B statement? Does everyone sign it? For example, those born in countries with high or intermediate endemicity should be tested for hepatitis B antigen, core antibody, to determine the infectious status. So do we know that they have a negative antigen and they've been negative? The next page is an example of the hepatitis B statement. Do you get this on all your healthcare professionals when they come in? They're interested in it. They don't know their immune status, or they've said that they do not have potential for infection. We make everyone coming into our organization sign a status that they either want it, don't want it, or they don't have exposure. But that gives us some type of documentation. For the Tdap, the tetanus, diphtheria, and pertussis vaccine, this is especially crucial for the pertussis part. Healthcare professionals, regardless of age, should receive a single dose of Tdap as soon as feasible if they have not previously received the Tdap. The minimal interval was removed, and the Tdap can now be administered regardless of the interval since the person last had their tetanus or diphtheria-containing vaccine. Hospitals and ambulatory care facilities should provide Tdap to the healthcare professional and use approaches that maximize vaccination rate. So one of the things is, do you offer the Tdap free of charge? Did you know that teenagers and elderly are the most common carrier of pertussis? And babies cannot be immunized and die from pertussis. So these are all important when you're looking at these vaccines. The influenza vaccine, I think we've all heard about this on the rise. The emphasis that all healthcare professionals, not just those with direct patient care duties, should receive an annual influenza vaccine. Comprehensive programs to increase vaccine coverage among the healthcare professional are needed, and in some places they're required. Influenza vaccination rates among healthcare professionals within facilities should be measured and reported regularly. So you want to do it for you, your patients, your residents, your coworkers, and your loved ones. And as a healthcare professional, it is our ethical responsibility. The meningococcal vaccine, with an anatomic and functional asplenic or persistent complement component deficiencies, they should now receive 2-dose series of the meningococcal conjugate vaccine. This is because they are definitely at risk for getting meningitis. Healthcare professionals and HIV infection who've been vaccinated, they should also receive 2-dose series because of their immunity being low. And the healthcare professional who remains in groups of high risk are recommended to be revaccinated every 5 years. Documentation of the vaccination in the healthcare professional's file. Do you all have this on file, or is there someone that you can reach out to with the contracted folks to get it, because you do have to produce it. You need to include the date of the vaccine administration, including those that had it prior to the vaccine and prior to their employment, the vaccine manufacturer lot number, edition and distribution date and language of the viz, the name and address and the title of the person administering the vaccine. Why go through all of this? Well, I think we heard, the story in the beginning. And this helps to rapidly identify susceptible healthcare professionals in an outbreak situation. It also reduces the cost and disruptions to the healthcare operations. And by having the accurate vaccination records, you can identify these healthcare professionals, and I'm speaking from experience, much more rapidly than you could if you didn't. Those with no history of vaccination or lack of documentation you can really focus on those when you're doing these during an outbreak situation, and again, to reduce the cost. Orientation and education documentation. So you need to document when you've oriented somebody, any education that you've given them, regardless of what they're doing. Infection prevention policies and procedures, modes of infection transmission, bloodborne pathogen exposures, prevention, TB information, hand hygiene, any of your state or local regulatory requirements, processes for reporting unsafe situations, breaches and infection prevention processes, education and competency training. Checklists are helpful in ensuring the standard of care with these folks. Your healthcare professional file, each record should include immunity status for the indicated vaccine preventable diseases, documented disease, vaccination history, serology results are some of those few, vaccinations administered during their employment, documented episodes of adverse events after a vaccination, and the date of the viz sheet that was provided to the healthcare professional at the time of vaccination. You should all have policies that are included for all your healthcare professionals. Bloodborne pathogen policies, illness call-offs, educate your healthcare professionals on signs and symptoms that would indicate the need to stay home to prevent these infectious conditions. Your exposure control plan. For example, you would do some of your hand hygienes, donning and doffing personal protective equipment, signs and symptoms of communicable diseases that need to stay home, draining skin lesion. They shouldn't have contact with patients or residents. They should not handle patient care equipment. Symptoms of a respiratory or gastrointestinal infection or other infectious diseases that they should report to their supervisor. And again, as we head into influenza season, they definitely need to stay home if they have the symptoms of influenza, so we need to educate them on that. Benefits of doing all of this is, grandparents need to get the Tdap before a grandchild comes in. It's proven that all of these folks are better to their grandchildren by having the immunization of the pertussis. They're not carrying it, they're not giving it. Younger people using it for school, building positive relationships with everybody on your team and in your facilities. A time to educate folks that may not have access to true medical information. They may not have a primary care provider or go to the doctor. Healthier non-employees means they get to enjoy the time the way they want to spend it. My picture of the waterfall, going to Hawaii versus being sick and being at home. Look at your employee health policies as a benefit, not a torture chamber with rules and regulations. And in conclusion, how do you determine who is on site in your facility from outside agencies? Do you know all of them? Do you know where they're coming in at? Do you know how long they're going to be there, who they're going to be taking care of, what type of contact they're going to have? This is very valuable to your organizations. Take care of them. If you take care of them, they will take care of you. You as a healthcare setting should have a method to determine that those employed by outside agencies are compliant with current education and training requirements, or are responsible for training them through the facility's current infection prevention and controlled education program. So in closing, does anybody know where all the unwritten rules are? We all seem to have those file cabinets. Terry Lee, I will now turn this program back over to you.
Thank you, Nancy. That was a very informative presentation, and it contained a lot of valuable information that hopefully everyone who's listening can use in their organization. That continues our slide presentation portion of our program. Now we would like to begin with our question and answer period. So Nancy, the first couple of questions that we have are coming from the same person, and she's asking, do you have a file on every contractor that comes in, including plumbers, air conditioning repair people, etc., that includes all of their information or all of their immunization statuses?
On some of the contracted facilities, we do have a file on everyone that comes in if they're using our employee health services. On some of them, we hold that back to that facility. So if the contractor wants to, they have a medical person there that wants to handle all of that and have it, that's fine, but they have to meet our requirements, and at any time we can audit them, we can ask for that documentation to see it, and they need to provide it. And especially when we have our friends at the Joint Commission or the health department come in, we need to have that documentation. So in some of them, yes, we do have them here in our organization, and some we ask that they wanted to hold them at their organization, so we at least have access to them.
Okay. And do you educate those contractors in regards to PPE, hand washing, transmission of pathogens, et cetera, or are the contractors responsible for that on their own?
Again, that's shared responsibility, but it's ultimately our responsibility to make sure it's done. So we do ask that they have some of our packets. Like we have some that are in paper packets, and they choose to do those as like a U-Learn or a sign-off when they do their mandatories at their organization, but they need to share that final sign-off page with us that they've completed it. And then in some of them, we do include them in our training, so they would have to go to our annual mandatories or come to our hand washing, modules or seminars, things that we conduct on the units. And certainly if they're here when we're doing them, we always do include them in any education that's on site while they're there. They can certainly take advantage of it.
Okay, and one question that I see here, and it's a good question, for all of these things that we're talking about here, whether you administer or the contracted workers have it back at their place where they work, do you recommend a certain type of document format to keep track of all of this? Or is it just everybody uses their own thing?
Everybody does use their own. However, we have a final checklist here that we check them off and say, like, have you completed all of these things? Again, like a hepatitis B vaccination or a statement. Like we have a little checklist that and a lot of our contracted facilities and our volunteers obviously use our checklist, but there are some that choose to use their own. As long as they can show us that they have met all of the requirements, I'm not opposed to that. I'm certainly whatever it takes to get the job done and work together to do it. But a lot of places have just gone to our checklist that we share.
Checklists are always a good idea. Okay, one question I have here, what do you do when your new employee is not able to supply you with a list of the vaccines that they've had?
Then they need to obtain titers, because if they, the titers will ultimately tell you if they're protected. So a lot of folks, their, pediatric doctors have deceased and they can't get those records, or they've moved out of the country to another country. They need to get titers through their current physician or their current employee health program and provide those titers to show us that they're protected. Otherwise, if you cannot provide anything, you cannot be in our facility.
The checklist that you just referred to that you use to make sure that everything's accomplished or met, do you have a copy of that you could provide to us that we could send out via email to our participants today?
I do. I can send that over to you after we're done.
All right. We will send that out then. And another question is, so you're recommending that all staff should receive the Tdap?
Yes, we are. Well, in most of our facilities, especially if they're pediatric or have the OB-GYN, like with pediatric and they're dealing with kids, we do recommend it. And even in our geriatric facilities, we recommend it there because they're the highest incidence of carrying it. So, yes, we do recommend it, but, I would say pay particular attention to your pediatric and your gynecological services if there's any of those. They really do need that. It's part of a mandatory program for them.
Okay. The next question is from a facility that has many student nurses on site. And while they do have requirements through their university, do you suggest that they have copies on file in their long-term care facility? Also, they mandate the annual flu vaccine, but no other vaccine data is kept on file, again, just for long-term care specific.
Yes, for any of our students, obviously that gets into a lot of them, and they cross over to so many of our different, because we have multiple places also. So we actually put that in our contracts with all of the schools that we work with, that they need to maintain specific records on site. So, for example, for Penn State University, if they have nurses or radiology people coming into our facilities, they all have to maintain those records on site that we could then get them from them should we need them in an audit or something like that. But they, again, use our checklist, and they have to make sure. And we periodically test those, even if we don't need them. We spot test them to make sure they are keeping those records because, you know, if we needed them, we could be fined. We ultimately, as the employer, are held responsible for that, and we could hold the fine and the recommendation on how to fix it if the records aren't available.
Okay, we only have time for a couple of more quick questions. So, Nancy, are you able to tell us what immunizations are they required to have on file other than information on tuberculosis and Hep B?
Well, I think a lot of that is based on your own personal policies, too. So, like in most of our healthcare facilities, it is our policy that they have to have titers for measles, mumps, rubella, varicella, because those are all diseases that we could see exposures later on with our patients and our residents. So influenza, you know, that's a mandatory policy for most healthcare organizations. So again, a lot of that comes by your individual policies, and it's driven from that. And obviously, the more that you have, the more protected your staff and your residents and patients are.
Thank you. And I think that answers another question that we have regarding is Tdap mandated, and that would be per your personal policy in your facility. And our last question, what if contract workers are non-compliant with the standards you have in place at your facility? What can you do?
Well, you have the right and the responsibility to not permit them to work in your facility until they meet your compliance guidelines. In most of our organizations, they are not allowed to come in until they are compliant, just because there is that, you know, that's going to be the one that you end up with an exposure. And I can tell you those exposures take 3 times longer than obtaining the compliance. So, and, you know, for me, a lot of times, especially if they're students or they're groups of people that they're not always at your organization, they could be away on spring break and they're in another country, and it's really hard to get a hold of them. It's much easier to get this information up front and you have it, because we don't always hear about an exposure right at that moment. We hear about it a week or 2 later. So trying to get a hold of people that might have left your organization at that point, we're ultimately responsible for reaching them and explaining to them what's happened.
And I think that's the point of why we did the topic that we did today. We want the group to understand that you do have not just the right, but the responsibility not to permit contractors who do not follow your standards into your facility. Okay, thank you, Nancy. This concludes our webinar.